audible. You can start.
So the slides are visible, Girish?
Yes, we start.
Yeah, slides are visible and I am audible.
Now it's visible. Okay.
Right. Okay. So thank you, Dr. Girish, for kind words of introduction. So this is my latest CV. I do not know, that is 5-year-old CV. So the publication from 110 are now 170. So
that's great.
so anyhow, thank you RSSDI team for inviting me for this lecture, and the topic allotted to me is prevention of GDM. Is it possible? Now this is in brief about the agenda, which I am going to cover over next 18 minutes or 19 minutes. Now the definition of GDM has changed over last few years. Initially, we used to diagnose GDM by definition any degree of glucose tolerance with onset or first diagnosis during pregnancy. But this has got caveats. Based on that, in 2015, GDM is now defined as diabetes diagnosed in second or third trimester of pregnancy, and that was not clearly overt diabetes. It means two important things. Diabetes diagnosed in first trimester is not GDM, it is diabetes. Similarly, if your FPG is more than 126 and postprandial is more than 200, it will be labeled as diabetes and not GDM. So there is a distinction between diabetes and GDM, which we need to understand. There is a huge prevalence of glucose intolerance in pregnancy, but what is important to understand that out of that, 90% of the glucose tolerance in pregnancy is because of GDM. Now we have done some of our own study from Haryana. Now this is a study where we have tried to find out the prevalence of gestational diabetes, which we found to be around 7%, and number of risk factors. Now why I'm showing you, because whenever we talk of prevention, first we have to understand the risk factors, only then we can talk of prevention. And in this study, we have shown that advanced maternal age, higher educational status, lower socioeconomic status, pre-pregnancy body weight, BMI, weight gain, acanthosis nigricans, this we have shown for the first time in literature, that acanthosis nigricans, just a physical examination give you a clue that this lady is going to have GDM, family history of diabetes and hypertension, and past history of GDM. Then we have also assessed prevalence in rural Haryana. Again, there's a very few studies regarding prevalence in rural population. So this is a hardcore rural population study where again we identified that the prevalence of diabetes from different criteria varies from 9% to 14%. So definitely there is a huge burden of GDM in our population. But then why we are concerned if this is not diabetes, this is a pre-diabetic state? The reason is there are maternal and there are neonatal consequences. What are the maternal concerns? They have been highlighted here, which include right from preeclampsia to increased UTI, increased need for cesarean sections, polyhydramnios, and postpartum uterine atony. Not only that, these GDM mothers are actually at increased risk of future development of overt diabetes. The conversion rate is overall 4% per year. Around more than 50% of these women are going to become diabetes after 10 years. They're also at increased risk for developing cardiovascular complication. If we look for concerns to the baby, this include macrosomia, which means increased risk of birth injuries, which are highlighted here, fetal hypoglycemia, fetal hyperbilirubinemia, fetal hypocalcemia, and increased perinatal mortality. Apart from these birth issues, these children were born to a GDM mother. They have increased chances of childhood obesity. They are at increased risk of development of future diabetes and neuropsychological outcome. And based on all these information which is available to us, in St. Vincent Declaration, it has been said that outcome of diabetic pregnancies should be similar to non-diabetic pregnancy. However, unfortunately, we are still miles away from reaching this goal, and we have to do lot of things in terms of prevention and management of GDM. And I am going to discuss only about prevention of GDM. So why prevention of GDM? So what are the potential benefits? If we reduce GDM, we are going to reduce immediate maternal and fetal adverse outcome, which I have discussed with you. It is going to have a marked improvement in risk of long-term sequelae, which again I have discussed with you. And not only that, if we do this, it will result in reduction of economic burden to healthcare system. Now it has been identified that for care of GDM, the cost of pregnancy delivery, if we consider in vis-a-vis non-GDM, it is 3 times higher. So it is a huge burden on healthcare system. Now these are number of risk factors which I have again told we have identified in our own study, right from advanced age, obesity, short stature, family history of diabetes, and so on. But then there is another way to look at risk factors when we are talking of prevention. We have to understand there are some factors which are non-modifiable and there are some factors which are modifiable. The non-modifiable risk factors include our ethnicity, underlying history of polycystic ovary syndrome, previous pregnancy with GDM, family history of type 2 diabetes, and advanced maternal age. And as you see, we cannot change any of these risk factors. On the other hand, the modifiable risk factors include pre-pregnancy body weight, means overweight and obese females. Dietary factors, what type of diet an individual is consuming. Physical activity, the level of physical activity. So basically, these are the 3 important modifiable risk factors which might be going to change the way increasing prevalence of GDM is seen in our society. So when it comes to prevention of diabetes, there are 3 important aspects. Lifestyle interventions, which include diet, exercise, or combined diet and exercise. Dietary supplements, which are given over the counter by so many doctors, and pharmacological therapy. Now, what I am going to discuss over next few minutes with you is regarding studies in brief, and this is how you should learn from those studies that, as you see, green with tick, clear evidence of benefit, red with cross, clear evidence of harm, and so on. So this is a strength of evidence which I have tried to enumerate it against the number of studies. Now, if we look at dietary interventions, these are 2 important studies which are published in 2017, where standard versus intense dietary advice is compared in understanding the decreasing prevalence of GDM. As you see clearly, the number of participants are low and the quality of evidence, which is graded as either low or very low. And if you see the relative risk, it varies from 0.6 in first study to 0.91. But if we conclude the dietary interventions, unknown benefit or harm of dietary advice versus standard care on risk of GDM in these 2 studies. If we see the risk of benefit of exercise interventions alone, and again, this study is published in 2012, and in this study, again, it has been shown that the relative risk crosses the level of 1 and the quality of evidence is low. So we can summarize, again, there is not much benefit of exercise alone vis-a-vis standard antenatal care in reducing the risk of GDM. The third way to do it, combined diet and exercise. Now, this again has been studied and has been published in Diabetes Systemic Reviews in 2017, where both diet and exercise are given in comparison to the standard of care. And for the first time, when diet and exercise both are combined, it has been shown that there is possibly a benefit of combined diet and exercise on reducing the prevalence of GDM with relative risk of 0.85, and the quality of evidence is moderate. So if we summarize these 5 important studies, as I have told you, isolated dietary advice, use of low glycemic index, the effect on GDM is controversial. Use of exercise alone, the effect on GDM is controversial. Not only that, the quality of these studies are grading as very low. In contrast, the study which is published in 2017 and in Cochrane meta-analysis, it has been seen that it is a combined diet and exercise intervention which has got some benefit on reducing the prevalence of GDM with grade of evidence moderate. Now coming to an important study which is known as Radial Study. What is Radial Study? Gestational diabetes mellitus by lifestyle intervention. Lifestyle intervention include diet and exercise, and this is a Finnish gestational diabetes prevention study. This is like DPP study which is done for type 2 diabetes. In this study, 540 women were enrolled. They were given OGTT and based on diagnosis of GDM, they were allocated to intervention or to a control group. In the intervention arm, ultimately 144 women were available for analysis, and in the control arm, these are 125 women. What this study has shown? This study has shown that in intervention group, the prevalence of GDM is 13.9%, vis-a-vis 21.6% in control group, with a significant p-value, which means the Radial study has concluded that a moderate, individualized, remember it is individualized, lifestyle intervention reduced the incidence of GDM by 39% in high-risk pregnant women. Now, if we see the meta-analysis, which is including 29 randomized controlled trial involving more than 11,400 patients, as you see this forest plot graph, clearly it shows that lifestyle intervention are beneficial with a relative risk of 0.82, which means they reduces the incidence of GDM by around 18%. So definitely in women who are at high risk for GDM, if lifestyle intervention is given, it is going to prevent development of GDM during pregnancy. But then an important question comes, when should we initiate the lifestyle intervention? Should early in the pregnancy, that is during the first or second trimester, or late in the pregnancy? Now, if you see the meta-analysis again, it has been clearly shown that if you start lifestyle intervention before 15th week of gestation, it will result in 22% reduction of incidence of gestational diabetes. In contrast, if it is started after 16th week of gestation, then it will result only in a non-significant 3% reduction. So the message from all these trials is that those women who are at risk for GDM, they should be subjected to appropriate individualized lifestyle intervention, and it has to be initiated right at the time of conception. We have not to wait more than 16 weeks when the benefit is not seen even with lifestyle intervention. So the lifestyle modification during pregnancy, especially if initiated before 15th week of gestation, can reduce the risk of GDM. Now the next important part is dietary supplement intervention. Now there are a number of studies involving various supplements like omega-3 fatty acids, myo-inositol, probiotics, vitamin D alone, vitamin D plus calcium, vitamin D plus calcium plus other vitamins or minerals. And as you see, again, I have tried to summarize in one slide with quality of evidence. And again, I will try to summarize for you so as not to confuse you. If we see omega-3 fatty acid, the study have shown clearly no evidence. And the relative risk is 1.02, and it is not found to have any effect on reducing the incidence of GDM. If we see myo-inositol supplementation, which is a type of B complex again, possible benefit, myo-inositol actually reduces insulin resistance. It is a drug again used in women with polycystic ovary syndrome. It has been shown that relative risk is around 0.43 with upper bound confidence interval 0.64, which means possible benefit when it is used in high risk women who are going to be pregnant. It has shown that reduction in incidence of GDM. If we see vitamin D supplementation, we have done in our own study. Again, I am not showing here because of shortage of time. In vitamin D study, we have shown that it is only severe vitamin D deficiency which is associated with increased prevalence of GDM, not vitamin D insufficiency or mild deficiency. And in this study, they have shown that it is possible vitamin D supplementation in those whose vitamin D levels are less than 50 nanomoles per liter. Possibly there is a role in reducing the incidence of GDM. Not only GDM, it has shown beneficial effect on reducing the incidence of preeclampsia during pregnancy. Coming lastly to probiotics with the dietary intervention, again, unknown harm or benefit So again, not of proven benefit. So out of dietary supplements, it is myoinositol and to some extent vitamin D, which has been found to be beneficial. And again, as I have told you, these are the grade of evidence in different colors with query plus or equal marks. As you see clearly, it is myoinositol and vitamin D, which has been shown to be of some use in reducing the incidence. Lastly, coming to therapeutic intervention and focusing on a single drug, which is metformin. Now, metformin is commonly used in early pregnancy and even in PCOS women. And it has been used in second and third trimester for treatment of GDM. However, current evidences do not support metformin as a preventive option for GDM. Now, this is an Empower study. This is a randomized study involving 449 obese women who were given metformin in a dose of 2,500 milligrams per day. And then Empower study did not find any difference in GDM prevalence, maternal weight gain, or maternal lipid metabolism. In fact, even the birth weight is comparable between the two groups, and metformin use was associated with more diarrhea, 42% vis-a-vis placebo, that is 19%. Two another studies with metformin where it has been shown that the results are not supportive. In fact, they are equivocal, and it has been shown that in only those women who are obese, whose BMI is more than 35, when we have used metformin in such type of women, there is some chance of reducing maternal weight gain. And this weight gain is reduced by around 1.7 kg, which might have resulted in some better outcomes. However, the GDM incidence again was not different. Lastly, we are in an era where overweight and even obese individuals are now undergoing bariatric surgery. It has been shown that for marked obesity, when these individuals have undergone bariatric surgery, because of marked loss of body weight following bariatric surgery, it has shown reduced GDM prevalence, lower rate of large for gestational age infants, and reduced prevalence of pregnancy hypertension. But then there are many disadvantages. An increase in impaired fetal growth reflected by higher rates for short for gestational age infants, higher incidence of preterm deliveries, and surgical treatments which have caused malabsorption and are followed by greater reduction. So definitely we have to be cautious if we are subjecting young unmarried girls and asking them to undergo bariatric surgery, because in future they are going to be married and they are going to have childs. So these are some of the issues. Now, before I conclude, when we talk of prevention, it has been told to us in our community medicine classes during MBBS lectures, there are three levels of prevention: primordial prevention, primary prevention, and secondary prevention. Now, when we talk of prevention of GDM, it is primordial prevention, that is lifestyle intervention started in pre-puberty and pubertal phase, or primary prevention when they are started in preconception stage. What actually has been done worldwide is that most of the time focus is on secondary prevention when women become pregnant and they are at high risk for developing GDM. And probably that is a reason, as I have told you, that large number of studies, whether it is exercise, diet, dietary interventions, or metformin, have failed to bring about significant change in incidence of GDM. So we have to change our approach. We have to go directly to primordial and primary prevention, because whenever we talk of prevention, it is primordial and primary prevention which is more important rather than secondary prevention. Before I conclude, when we talk of prevention of GDM, we have to think a life cycle approach. Life cycle approach means at which stage of the life we are seeing the individual and what are our health resources. In life cycle approach, in pre-pregnancy, if we are seeing all females, children, adolescent girls, and those unmarried girls who are less than 30 years of age, they come under pre-pregnancy phase. And in all these individuals, there is a need to initiate community awareness, assessment of risk for GDM, initiate early therapeutic lifestyle changes, and then only we can change or decrease the incidence of GDM in our society. In contrast, if we see women in pregnancy phase, as has been commonly done in routine clinical practice, we have to universally screen all pregnant women, identify them at the earliest, initiate medical nutrition therapy, But remember, in pregnancy, you have not to wait more than 2 weeks. If after 2 weeks of therapeutic lifestyle change, the glucose level remains more than 120 milligram per deciliter, we have to initiate therapeutic drugs. Lastly, postpartum phase is not important. This is a time when the woman is most receptive because she has already suffered an episode of GDM. She should be given advice about therapeutic lifestyle, not only to her, but even to her baby, that how your baby in future might be at a risk if he is or she is not given proper lifestyle changes as that young baby is growing to grow up. So friends, whenever we talk, I have told lifestyle approach in terms of GDM. But I believe when we talk even about diabetes in general, in type 2 diabetes, we have to understand life cycle approach whenever we talk of prevention of GDM. To conclude with, GDM prevalence is increasing in India as well as globally. For prevention of diabetes, GDM, we have to identify high-risk women. Lifestyle interventions are useful. There is not much role for drugs, for dietary supplement. There is some role for myo-inositol and metformin, although more evidence is needed for lifestyle, dietary supplement, and pharmacological measures. Thank you very much.